So maybe you can expand on that and talk about the payment approaches that are being now suggested by ASCO.
Yeah, so ASCO's payment approach, I mentioned earlier, one of them begins with kind of the baby steps. Take fee-for-service, add patient management fees to it, and make people accountable for lowering costs. I think Barb has done a wonderful job of showing how much you can lower hospital costs if you decide that's what you're going to focus on. What we haven't done yet is shown how much we can reduce unnecessary utilization of therapies through that kind of process. But if you make physicians accountable for those kind of things within that context, that's going to get you part way. The next step of the ASCO model is to say, okay, now we're going to pay you a monthly bundle. Within that bundle, then you decide how you're going to innovate and provide the care. If it makes sense for you to have follow-up visits that are group visits sometimes, you can now do that. If you want to hire a palliative care doc in your practice, something you could never afford to do before because fee-for-service just didn't pay to make that work, now you can hire a palliative care doc and I can focus my efforts greater on taking care of the part I do best and let the palliative care doc focus on things that I don't do quite so well maybe, and innovate within my practice. I can use my nurses to the highest degree of their license. I can use nurse practitioners to a way that makes sense, and then I am accountable not just for the costs, but also for the quality of the care that I give. The final model, and some practices may never get there, and it may not be the right thing to do, is going to be all-inclusive bundles. Either a drugless bundle, because I can't control the cost of the drugs, or a drugs-in bundle saying, no, but you may be able to control utilization enough to manage that risk. I think there are many practices that will never be to a point where they can manage that kind of risk just because they won't be big enough. I think that the middle ground may be the place that would be the perfect place. My challenge is that right now we put all of our eggs in an OCM basket. There are other models that need to be tested. If you only test one model and you say it kind of worked, you haven't done your job. You need to test a lot of models and say what needs to work. And the idea that we're going to take 100 practices and spend 5 years finding out whether one model worked makes no sense to me.
Right, I agree. We face the challenges that we have now 5 models in RCCA. So we have a bundles model with one payer, we have a OCM light model with another, we have 2 versions of shared savings with 2 others, and now we're applying for the CMS OCM model. And to set up the requisite infrastructure to do that, we wouldn't be able to do that if we weren't of our size. Let me switch gears. One of the things that comes up a lot, and Mike, maybe you can bring some color to this, is that bringing U.S. drug prices into parity with foreign prices, or maybe the question should be reversed. Some people feel like the United States subsidizes the rest of the world. Is that true when it comes to drug pricing? And is there a solution to this if it is a problem?
So certainly not my area of expertise, and nothing that I deal with at the health plan. When I was with U.S. Oncology, it would drive us crazy. I think that I don't see that as being a pragmatic development. I just don't see it.
I think you have to understand why there are differences in drug prices. The reason that the drug prices are lower in the rest of the country is because they've been willing to say no. You have no negotiating power if you are going to pay for the drug and all the drugs at the end of the day. So the reason that they can do it is because they've said, if this drug doesn't bring enough value, we are not going to pay for it, which means the patients are not going to have access to it. Until you're willing to do that, until society and government is willing to accept rationing, then you're not going to have lower drug prices, and you're not going to have parity.
Okay. So the last thing